My name is Caterina, and hopefully this is going to be an interactive session. And hopefully you can be able to learn a few things that you can implement in your area. I work at Newham Hospital, which is part of Untitled Trust, which is the largest trust in the country. It's a very challenging workplace. Our population is increasing every year, and is very high-risk population because they are very mobile. They come to this country when the women are heavily pregnant, and they are very mobile, and the area is very, very, very deprived. And so we have a high activity and high acuity. And we speak more in our borough. There are spoken more than 170 languages. So you can understand the challenges we have on an everyday basis. And last year we had 6,400 births. This year is 6,600 births. So you can imagine how stretched we are and how our midwives have to, everyday basis, fight with the workload because they have got a lot of patients to look after. In our triage, we have every month 1,000 women coming. So you can understand how the service needs to be able to bear with this kind of high acuity and activity. What was happening? When I started looking at this project was last year in September. And we just observed and we looked at what happening. And there was not a real triage. So the women were coming and the midwife were assessing the women one after the other without understanding the condition, without understanding which woman should have been prioritized. So you had a lot of women waiting there, and then because the midwife were assessing the women fully and managing the women fully before going to the next one, you can understand how safety was compromised there, because how are you 100% comfortable in saying that there is nobody there waiting, which is more in a condition, which has got a condition which is more dangerous than the one you are looking after at the moment? So we had long waiting. Last year, the CQC, when they did their inspection, they found out there was a long waiting for these women attending maternity triage. And obviously, we had high incidents. We had a cord prolapse and any other things. And the patient experience was not great because obviously we had women waiting long time to be seen by a midwife, and obviously were complaining a lot. And another problem was the location of triage. Triage was inside the delivery suite. So we were using 2 rooms that were delivery rooms as a triage. And then maternity assessment unit or day assessment unit was on the ground floor. So these women were going up and down, up and down. There was no ownership of these women because the triage midwife thought, okay, she needs to go to a maternity assessment unit. And then the midwife working in maternity assessment unit say, oh, she should have gone to triage. So that was happening. So that was the inappropriate location. And as well, there was a very small waiting room, which was very, very, very near the bereavement rooms. So you can understand that these women that had lost their babies, they had to hear women coming to triage and complaining about their contraction, their pain, was not ideal. So these women were complaining a lot. Was not compassion for these women. And the midwife were very stretched, very stressed, and they didn't know how to work in triage. They were just there working, and they were delivering care 360 degrees, taking bloods, putting cannula in, performing CTGs, and that was not the real how the real triage works. In quality improvement, when you have this, you talk about patient mapping. I don't like to use this wording, patient mapping, because this is about women. This is about their stories. So this is an example of a women's journey. So we follow this woman through her journey in maternity triage. And as you can see, so she came to triage for abdominal pain at 14:50. And after half an hour, she was seen by the midwife in triage. What we did, we took the history, we did some observation, analysis, we auscultated the fertile heart, and we palpated her abdomen. And the plan was to go to triage, to maternity assessment unit for a CTG and doctor review. Okay? Hours later, she was transferred to maternity assessment unit. They didn't do a CTG, and the doctor didn't see her. So she's still waiting. She was transferred back to triage because at 8 o'clock, maternity assessment unit closes. So again, no ownership, going back and forth. Okay, so 1935, she's transferred to triage. They did a CTG. At 8 o'clock, bye-bye, night staff comes. So hand over to the night staff. At 8:15, finally, she's seen by the registrar covering for gynae. They came over. So they did a history again, vaginal examination, CTG was interpreted, and the woman was reassured, and the woman left the department 20 minutes past 8. So in total, this experience is 5 hours, 30 minutes. I don't think that is good enough, so we had to do something about this. So our baseline data in September, October, was that 35 women only were seen by 15 minutes from their arrival, which means that 65% of women had to wait longer than 15 minutes to be seen by a midwife. And then 11% of women spent more than 4 hours in the department. This is a picture which drawing one of our consultants, she likes drawing, well, she's not the best, but I'm worse than that. But this shows you that triage can be a very, very scary place. You don't know what can come through that door. You can have this woman which is referred for high blood pressure, and a few minutes after she's been waiting half an hour, she can have an eclamptic fit. So that was the safety that is compromised. That's why we have to look at this, and we have to improve it. It was a lot of work about engagement. In every project I've been working, the majority of people don't want to admit that there is a case for change. They don't want to admit that there is a problem. So you have to spend a lot of energy to try to understand what is the problem, how can you resolve the problem. But the midwives need to acknowledge that there is a problem. So what we did a huge workshop, and we included all our midwives, healthcare assistant, doctor, and all the stakeholders, and all the multidisciplinary team. And we came out with all the fishbone approach. So we look at what are the problems, and we try to identify which are the solutions of them. These are our primary drivers, which process staffing, knowledge, equipment, and environment. I can make you some example about the process. We didn't know where to direct the women. We didn't know which women were eligible to go to triage, which women were eligible to go to maternity assessment units, because both of the areas were very similar, so the women were just stepping in. There was no clarity for women, there were no clarity for referrals, and there were no clarity for the staff themselves. And for this region, there was no ownership of, I work in maternity assessment units, these are the women that come through the door, this is what I have to do. So that was some of the process that we had to look at. Again, there was no a RAG rating, so red, amber, green rating. There was nothing that clarified for staff what to do and the management of some condition. No, we had a pro forma from another hospital, what was not in use, was never filled, and nobody never spent any time with the midwife asking them, do you like this pro forma? What do you think about it? Why is you're not using? So there is a lot of work was behind trying to identify the problems and then solution. So there was, for example, there was no clarity about scan review. A lot of women from antenatal clinic came to maternity assessment unit just for a scan to be reviewed from a doctor. There was no pathway. Staffing. There were no enthusiastic midwives who really wanted to work in a triage there. Just midwives that were in delivery suite that were sent to triage. So there was not the right staff there, the enthusiastic and motivated midwives there. Knowledge, we didn't know how triage works. They never seen a triage. There was not clarity of how triage worked. They didn't feel confident. So a lot of conditions where we asked the doctor to review them, and because the midwife didn't feel confident in managing those conditions. And then the equipment, the majority of the equipment were there, so we didn't have anything much to do. And then the environment was about the right location. We had to look about the location. So was that the right location? Near to the bereavement room with a very small waiting area, using 2 delivery rooms, was that something that we had to look at? So that's what we did. So these are some of the things that we did, that we implemented. We use a PDSA approach. So as I said before, is that ask the midwife, you implement something, for example, an audit tool or a pro forma. Ask the midwife, because they are the one who will be using it, what do they think about this? Is it clear enough? Is it easy to follow? Is it easy to complete? Otherwise, you are likely to fail, because the people that will be using it, they don't know how to use it. So we implemented this pro forma, which is got the red, amber, and green category, and we implemented a white category because not everything needs to be managed on the same day. Some of these white category are women coming for symptoms like colds and flu, or women coming with the unrelated pregnancy condition that are not related to pregnancy. So some of the conditions, the women can self-medicate, like go to pharmacy, go and see your GP. So some of these conditions don't need to be seen within half an hour or 1 hour. So we implemented appointments in maternity assessment units. So we stopped women to just stepping in maternity assessment units because we give them appointments. So enthusiastic midwife, it's important to have the right people in the right place. So we put out an express of interest for midwives that really, really want to work in that stressful environment, but people that really, really want to work there, now they're working there. And where to direct women. So we engaged a lot with our GPs, with the scan department, with the delivery suite, to try to identify which condition the women should go. And so we give this clarity. And we implemented this clinical handbook with all the management of the different conditions and all the clarity about where to direct the women. So we implemented maternity assessment unit appointments. We implemented and we relaunched the care bundles because are you aware of the care bundles, what they are? I assume, you know, yeah. Our care bundles were not used. And I think it's because the midwives they were never told how to use them. So we launched again, we looked at them with them, and we made it easier for them to use. Appropriate location, we talked about that. What we did, we asked the staff, what do you think we should be doing? Do you think we should be changing the process? Do you think we should be changing the location? So we did an options appraisal, and the staff came back to us and they said, we need to change the process, we need to change the location because it's not appropriate. So we did change the location. Now triage and MAU are on the same level, just very, very near, one door and then next door. So we have 4 midwives, 2 in triage and 2 in maternity assessment unit. They work as a team. They cover each other for breaks. There is ownership on that area because now there is one team and not 2. And it's much better for the midwives because they can learn from each other, and then for the women. What we did as well, we thought, why low-risk women have to come to a high-risk environment like a triage. So we decided to have a low-risk triage in the birth center, which is great for the women and is great for continuity of care. So these women, when they think they are in labor, they come to our birth center. They are assessed by the midwife, which is in the birth center. If they're not in labor, they go home. We reassure they go home. When they come back, they see the same midwife who looks after them in labor, and that is very, very good. Release the pressure on your high-risk triage and improves continuity of care and outcomes. So what we did, we had some targets that we have been looking at. So arrival from time from arrival to triage 15 minutes, appointments within half an hour to be seen from your appointment, and then total time spent in department 4 hours. And some of the colleagues say, oh, let's think about 90% target, 95% target. I think it's important to be ambitious, and I think it's important that all of your women are seen by these targets. I firmly believe that if you set yourself a target that is maybe more achievable, like 80%, you're more likely to achieve that target. However, if you set 100% target ambition and you achieve 98% or 90%, it's better than 80%. So just an advice from me is just try always to set a very, very high ambitious target, because you are more likely to have higher, better outcomes than if you have lower targets. Our results, that's what you want to know. So in the first week, we had from 35 to 73% of women that were triaged by 15 minutes. That was the big launch, a lot of midwives, a lot of managers working there, so we had great results. However, after 2 months, the results a little bit went down. So because we don't want this to continue, we thought we need to do something about it. And I'm going to tell you later what we are doing as well. So these are the results at the moment. So women staying in the department for more than 4 hours reduced as more than half, from 11% to 5%, and the median of time spent in the department is 27 minutes. Sorry, 1 hour, 27 minutes. MAU appointments, half of the women are seen within 30 minutes of their appointment. The range is between 2 minutes and 1 hour, 28 minutes, and the median is 27 minutes. Are you able to read the quotes from one of the women? So this is one of our women, Charlotte. She was very happy and impressed with the service. I'll just leave a few more seconds. Next step, because we don't know to go back of how it was before, we thought we need to give we need to make our midwives confident in looking after these women without sending all these women to be seen by a doctor. So we're going to have on Thursday, so in 2 days' time, we're going to have our first triage study day. We're going to have scenarios for the midwives to work on together. We're going to have one of our consultants is going to give a session on basic ultrasound for presentation scan, because a lot of women they wait a lot of time just to be scanned for a presentation scan to be scanned by a doctor. We're going to ask the midwife to design a care bundle, because again, it's important the people that are going to use that tool, they are actively involved in implementing and design that tool. So we're going to work with the midwife designing the care bundle. We're going to do quiz on where to direct women. So which of these conditions, for example, needs to be immediately transferred to delivery suite? Which of these conditions can have an appointment because it's in a white category? So again, Again, some of the midwives still are not 100% confident in when to do and when not to do a CTG, so we're going to have a session about that. And communication. Sometimes we don't communicate effectively for our women, and we all know that's a certain way of talking to our women sometimes we don't put in place. So we did some videos when I was a pregnant woman pretending to come to triage. So it's to show the midwife the nice way to talk to our women and how you can make a difference in that woman's day. We're going to review existing care bundles. We are reviewing the clinical handbook because we want the other 2 sites to implement, and we're going to do the next audit in October. Some of the key messages I would like to leave you with is engagement. It's important that obviously everybody is involved, especially when you have problems in in the patient flows, in the women flows. It's important you have your coordinators in delivery suite on board with this project, because they're going to be the one prioritizing the transfer of women. And then trading, it's important that you empower the midwife and teach them how to look, how to manage certain conditions. Sometimes we assume, because, okay, she's a midwife, she knows what to do, but never assume. Ask the people which gaps they have and which support they need, and make sure that you give them the support they need. We're going to give some clarity. It's important that you give clarity on RAG coding, so which conditions are red and which conditions are amber or green. We introduced very, very small cards like this that every midwife has got here or in their pockets, because for hygiene, you're supposed not to wear here, so they have in their pockets. They're laminated and they are very, very nice. So, and again, that RAG categories are in place, and again, is important teamwork and communication in everything we do. This is some of the acknowledgements of the people that have been involved in this project, some of the consultants. And the last slide is I really would like to thank all the midwives that work there on an everyday basis. And that's some of the midwives, the healthcare assistant and the receptionist. And that in the corner on the right, as this is the launch of our new triage. It's important that you celebrate success and you find time to party, because we work hard. We should be partying harder. So it's just when you do something, it's important that you celebrate with your midwife, nice cake and tea, because they really need that. So thank you very much for attention.